good morning, good afternoon, or good evening, depending on your time zone. I would like to welcome our global audience to session number 8, Long-Term Sequelae from Sepsis and COVID-19. My name is Imrana Malik. I'm an intensivist working at MD Anderson Cancer Center in Houston, Texas, in the United States, with an interest in sepsis in cancer patients. I'm also a member of the executive committee of the Global Sepsis Alliance and the co-chair of this Congress. Today, I will be your moderator for this session. A few housekeeping items before we get started. We have 6 wonderful speakers today, and we'll have time for approximately 1 to 2 questions after each talk. Of note, the first talk by Dr. Hallie Prescott is pre-recorded, so she will not be present to take any questions. However, please feel free to add your questions in the chat. We'll keep an account of them, and we'll forward questions to Dr. Prescott and then see the best method for reporting her responses back. That being said, it's my privilege to introduce our first speaker. Dr. Prescott is an ICU doctor and researcher at the University of Michigan in Ann Arbor VA Hospital in the United States. Her research focuses on sepsis survivorship. Specifically, she studies how sepsis fits into patients' longitudinal physiologic and chronic disease trajectories and develops tools to reduce post-sepsis morbidity. Dr. Prescott's research has examined healthcare use following sepsis and shown a substantial increase in the proportion of days alive spent in healthcare facilities among sepsis survivors. She has also found that hospitalizations with likely microbiome perturbations predispose patients to subsequent sepsis. Many sepsis survivors die following hospital readmissions for infections, suggesting that post-sepsis immune suppression is an enduring problem that contributes to late sepsis-related deaths. Taken together, Dr. Prescott's studies have highlighted the role of specific treatable medical conditions in driving post-sepsis morbidity. Let's start with Dr. Prescott's talk, which is titled, From Adults to Elderly Surviving Sepsis but Dying Sooner.
Hello, my name's Hallie Prescott. I'm an adult intensivist at the University of Michigan and the Ann Arbor Veteran Affairs Hospital in the United States. It's my pleasure to be speaking to you today about surviving sepsis but dying sooner. I've listed my disclosures here. I have no financial conflicts of interest. I've listed my grant funding and also relevant roles, and I'm just obliged to tell you that I'll be presenting my views and not views of the U.S. government or the Department of Veteran Affairs. The work that I'll be discussing was really motivated by this study that I led back in 2014 that looked at healthcare utilization surrounding a sepsis hospitalization. This examined a cohort of about 1,100 patients who had survived a sepsis hospitalization, and in this figure here shows the proportion of that cohort who was residing in an inpatient healthcare facility on any given day in the year leading up to sepsis and in the year after discharge. And then here in black shows the proportion of the cohort that had died in this year after sepsis. And so we were really struck by this very high rate of mortality in the year after initially surviving a hospitalization for sepsis. And there had been a variety of studies really all showing this high rate of mortality, but it was unclear whether this was a result of sepsis itself versus merely a reflection of the type of patients who are at increased risk for developing sepsis, namely older patients or patients with underlying chronic conditions. And there had been this systematic review published in 2016 that had examined these studies and had concluded that there was insufficient epidemiological evidence to confirm a causal relationship between sepsis and subsequent post-acute or late mortality among patients who had survived sepsis hospitalization. And so we sought out to answer this question because we hypothesized that sepsis does indeed increase one's risk for death in the 1, 2, 3 years following a sepsis event. For this study, we used the U.S. Health and Retirement Study, which is a very large observational cohort study in the U.S., which has been following about 20,000 older Americans from age 50 through the remainder of their life. And we identified patients who had been hospitalized for sepsis, and we then matched them to 3 separate sets of comparators. First, patients who were not in the hospital, Secondly, patients who were hospitalized for a non-sepsis infection. And thirdly, patients who were hospitalized for sterile inflammation. And we selected these different comparators to answer different questions. So first, what is the effect of sepsis, including the effect of merely being ill and in the hospital? And then what is the incremental effect of sepsis above and beyond being in the hospital for other similar related causes, such as a non-sepsis infection or a sterile inflammatory cause, which at least at the time in the era of sepsis 2 definition were thought to be these kind of two key components of sepsis. So here, this figure shows the lists of different characteristics which we were able to match people on. So because these patients were participants in this large observational cohort study and they were surveyed periodically about their health, we had a lot of really rich information about them. So we were able to ensure that the sepsis patients were sort of indistinguishable from their comparisons on demographics, their prior healthcare utilization, their economic status, their health status, including things like their functional limitations and also their self-rating of health, which is hugely predictive of subsequent mortality, as well as the sort of traditional things we often measure, like their list of chronic conditions. So what did we find? So for the first comparison, sepsis versus patients who weren't at the hospital at that moment, we found that sepsis was associated with a 3.5-fold increased odds of late mortality, specifically deaths in the 31 days to 2 years following sepsis admission, which translated into a 22% absolute increase in late mortality. For the next comparison, sepsis versus a non-sepsis infection, we found sepsis was associated with a 1.6-fold increase odds of late mortality, a 10% absolute increase. And then compared to sterile inflammatory conditions, a 2.3-fold increase odds of mortality, or a 16% absolute increase. We did a bunch of different subgroup analyses trying to understand were there particular types of patients who were really at increased risk of late mortality after sepsis. And we found that there was no difference really across types of infection or age, sex, their self-rating of health prior to sepsis hospitalization, their number of medical comorbidities, their pre-existing functional status, or whether they resided in a nursing home prior to their hospitalization. But we did see that there was a fairly strong association here between how ill they were, specifically the number of acute organ dysfunctions they had during their sepsis hospitalization, and their subsequent late mortality, which tells us that the sicker you are during the sepsis hospitalization, not only the increased risk you have of dying acutely during that hospitalization, but also increased risk of dying after hospitalization among people who do survive. So our main takeaways here were that 1 in 5 elderly sepsis survivors had a late death that was due to the lasting effects of sepsis, not explained by their age or pre-existing health status. This translated, or sort of said another way, we found that half of the deaths in the 2 years after sepsis were unexplained by patients' age or pre-existing health status. A key strength of this study was the very detailed information that we had on patients' pre-sepsis health status, whereas a key limitation was that our cohort was limited to patients ages 65 years and older. And so while we did not see a difference across age within our study, our entire study was limited to older patients, and so we're less able to assess whether the same holds true for younger patients hospitalized with sepsis. Until this study was published just earlier this year. This study examined adult patients ages 18 years and up, so a much broader age range, hospitalized with sepsis across all of Ontario, Canada, and compared them to adults who were hospitalized for other causes, not sepsis, but matched by age, sex, socioeconomic status, urban versus rural residents, prior comorbidities, and prior healthcare resource utilization. And here, this table shows the main findings of their study. So here, each row is the different sort of time periods that they assessed. So they looked acutely the first 30 days, 30 to 180 days, and then all the way out to 5 years for this cohort. And they found that patients hospitalized with sepsis had an increased risk of mortality. So here this shows the hazard ratio are elevated for patients hospitalized with sepsis versus their comparison. And this remains elevated for the entire duration of the follow-up out to 5 years. Additionally, presented in their supplement, they completed a subgroup analysis where they examined this association by age. So they divided their cohort into patients age less than 65 years, 65 to 84, and then greater than 84 years. And they found that the strength of this association was actually strongest in the younger patients, less than 65, and attenuated in the older patients. So really extends the findings of this prior study to show that this association persists across adult patients hospitalized with sepsis. So the main findings of these two studies are that patients after sepsis have a heightened risk for mortality, which is not explained by age or pre-existing health status. This association is present across the board, but particularly stronger for younger patients, and also stronger for patients who have greater illness severity during their sepsis hospitalization. I highly suspect that the very same thing is true for patients with COVID-related viral sepsis, although these studies were both completed using data from before the pandemic. So what are the implications? I think the key takeaway for me is that this data suggests that we can improve longer-term outcomes for patients who survive sepsis by providing better care during and after sepsis. If all of these subsequent deaths were explained by age or pre-existing health issues, then we may be less able to move the needle. The fact that most of these deaths are unexplained by pre-existing health status suggests that we may be able to reduce them by better care during and after sepsis. So how can we do that? So here I will close by pointing to you to some other sort of resources. The first is a review article that I wrote with Derek Angus, which was published in JAMA in 2018, called Enhancing Recovery from Sepsis. This was a large systematic review looking at the literature regarding outcomes from sepsis and providing essentially pragmatic recommendations about best practices both during and after sepsis to promote or enhance better recovery. This was then followed up with a study led by Stephanie Taylor called The Association Between Adherence to Recommended Care and Outcomes for Adult Sepsis Survivors. So essentially, they did a chart review for several hundred patients hospitalized with sepsis in a healthcare system in North Carolina. And they looked specifically to see whether patients were receiving these care practices, which we had recommended in this prior review. And they found that these care practices were indeed strongly associated with reduction in rehospitalization and reduction in mortality in the 90 days after sepsis, but only 11% of patients in their cohort got all of these recommended practices. So again, sort of more data suggesting that there is this kind of like opportunity for us to enhance recovery for sepsis by better care during and after sepsis hospitalization. So again, I will close there. It's been really a pleasure to speak with you today, and I thank the organizers for an excellent conference. Take care.
Excellent. We're very happy to have that talk by Dr. Prescott, and sorry to have missed her being here in person, but we'll hopefully be able to get questions over to her should there be any in the chat. Now let's move on. We'll be moving on to our next speaker. I'm happy to introduce Dr. Jerry Zimmerman. He's a professor of pediatrics and anesthesiology and a senior faculty member of the Division of Pediatric Critical Care Medicine at Seattle Children's Hospital and Harborview Medical Center at the University of Washington in Washington, USA. Since 2010, he has served in leadership roles for the Society of Critical Care Medicine and was president for that organization from 2018 through 2019. Dr. Zimmerman has been an editorial board member of the Critical Care Medicine and Pediatric Critical Care Medicine since 1993. In 2009, he received the American Academy of Pediatrics Section on Critical Care Distinguished Career Award, and in 2020, the Society of Critical Care Medicine Distinguished Service Award. Dr. Zimmerman was principal investigator for the NIH Life After Pediatric Sepsis Evaluation Lapse investigation, and is the co-principal investigator for the ongoing NIH interventional trial on on stress hydrocortisone in pediatric septic shock. Dr. Zimmerman's talk today is titled Informing Pediatric Survivorship with Quality of Life Indicators. Where does the data guide us? Welcome, Dr. Zimmerman, to the floor.
Thank you, and greetings to all of you listening from Seattle, Washington. I first should acknowledge support from the National Institutes of Health here in the United States for supporting the LAPS investigation, which I will speak about a little bit later in this talk. Well, we should start with this notion that at least for children, sepsis mortality has really declined substantially in the past several decades, at least in resource-rich countries. But at the same time, it's interesting that sepsis cases in children have increased. And this largely reflects in resource-rich countries the success of intensive care medicine, including rescuing children with septic shock. So in the intensive care unit, we intensivists really focus our efforts on recognition, stabilizing, and resolving organ dysfunction. That's basically our job in the intensive care unit. And we feel pretty good when that organ function dysfunction does resolve. The patient survives and can leave the ICU. That's considered a pretty good success. But what I'm going to talk about today is the burden of morbidity that these patients who survive their sepsis carry with them long after they leave the hospital. And one way of describing all of this morbidity is the impact on individual health-related quality of life. So currently, this is sort of the big picture. Mortality at 1 month for children with septic shock is about 10%. However, among those children who survive, and really nobody has looked at this until recently, about half of those children exhibit a substantial deterioration of their health-related quality of life from baseline. Well, in Seattle, our group got interested in this concept of morbidity among survivors of sepsis with this investigation by Dr. Angela Chai, who looked at, in a descriptive study, approximately 7,000 children in the state of Washington. This initial figure displays the risk of readmission after a index case of sepsis, and that risk divided as a function of chronic comorbidities, oncologic, non-oncologic, and then previously healthy children. So there is an ongoing risk for readmission to the hospital, suggesting something is going on after these children experience sepsis. If you dig into her data a little bit more, you find that in this cohort, approximately 7% died in the index admission, another 7% died subsequently. And interestingly, among the survivors, 50% almost had at least one readmission. The majority of these first readmissions, the vast majority, were either urgent or emergent. And at least to me, almost half of these first readmissions involved another infectious disease diagnosis. More recently, Dr. Elizabeth Killian, also from Seattle Children's Hospital, specifically asked the question, when children who were hospitalized with a case of sepsis underwent follow-up, how many of them lingered below their baseline health-related quality of life? And in a cohort of almost 800 children, she identified that almost 1/4 of them failed to recover to their baseline quality of life with follow-up. And then In regression analysis, she identified that septic shock, older age, immunodeficiency, and duration of stay in the hospital were all significantly and independently associated with this declination below baseline quality of life at follow-up. So this brings us to the LAPS investigation, Life After Pediatric Sepsis Evaluation Study. This to date is the largest prospective descriptive cohort investigation that really examined what happens to kids after an episode of septic shock. This study generated a very rich database, but it focused, and for the purposes of this talk, it really focuses on serial longitudinal assessment of health-related quality of life following exposure encounter with septic shock as compared to baseline. So children enrolled in this study really exemplified the complete spectrum of childhood in terms of age. About 45% were female, and 17% had some immunodeficiency. In terms of resource utilization, all of these as median values. These children required about 9 days in the PICU, 16 days in the hospital. They required about 3 days of vasoactive inotropic support and 8 days of mechanical ventilation. This figure sort of summarizes in terms of absolute scores the profiles of quality of life, in this case with two different assessment tools. The FS2R utilized for children with severe developmental delay. We could talk a lot about this slide, but the point I want to make is that somewhere between 1 and 3 months as median values, these children sort of approach getting back to their baseline quality of life. These are median values with the black bar. However, I want to point out the large error bars below, which indicate that a large proportion of these children are not back to their baseline, even out as far as 1 year following the sepsis event. So the other way of looking at this again is this concept of what proportion of children fail to return to their baseline health-related quality of life. And you could utilize many different thresholds to look at this. The minimal clinically significant difference for the PEDS QL quality of life instrument is 4.5 points. So what you see here is the proportion of patients failing to return to their baseline quality of life, either the minimal clinically significant difference, twice that, 3 times that, or 4 times that. And the dotted lines indicate that at 1 and 3 months, 50%, and then at 3 months, 40% of these children persisted below their baseline health-related quality of life. We also looked at the derivation sort of a composite measure that might be used in future clinical interventional trials for sepsis. And we defined poor outcome as either death from sepsis or persistent severe deterioration of health-related quality of life, more than 25% below baseline. And this poor outcome was noted in 37 and 28% of the cohort at 1 month and 3 months, respectively. In total, looking at what happened to these kids over the year following their septic shock, 13% died. And among the survivors, even 1 year following this event, 35% remained below their baseline quality of life. We examined a multitude of variables that these children might encounter during their critical illness, and with regression analysis, derived this model as one that was clinically meaningful, namely the summation of daily PLOD scores and organ dysfunction score, the summation during ICU stay. The highest vasoactive inotropic score may be reflecting intensity of the septic shock. And then, of course, any acute pathologic neurologic sign or event. Each of these was very significantly and independently associated with poor outcome, either death or severe health-related quality of life disability at 3 months. So the LAPS study concluded, as I said, that even at 12 months, 35% of children surviving sepsis remained below their baseline health-related quality of life. At 1 and 3 months, 37% and 28% demonstrated this idea of a poor outcome, death or serious quality of life deterioration, and then variables that quantify magnitude, duration of individual and composite organ dysfunctions were independently predictors or associated with poor outcomes following pediatric septic shock. So in our ICUs, we have this technology that allows us to support and ultimately resolve organ dysfunction, and we feel pretty good about that when we can do it because typically it's associated with survival. However, that's not necessarily exactly what the family and patient might be looking for. Of course, survival has to happen, but ultimately, all of us would like our patients not only to survive, but actually to thrive. So this idea of a good save in the ICU for septic shock it's not good enough anymore because we need to acknowledge that survival alone no longer expresses the complete impact for children who encounter sepsis. So the idea of a good save is great. It focuses us on making that survival from septic shock a reality. But now we need to move on to a new paradigm that intensivists will look for ways for interventions that will also maximize the health-related quality of life among children who survive their sepsis. Thanks very much for your attention.
Excellent. Thank you so much, Dr. Zimmerman. That was very intriguing information, especially with such longitudinal data. It's fantastic to be able to gather that. One follow-up question regarding the LAPS study. Were there any particular organ dysfunctions that were stronger predictors for poor quality of life outcomes, such as respiratory failure versus renal failure?
I think I showed that in our regression analysis, and as you might expect, and we're not the first to show this, if you have some type of a neurologic hit, new bleed in your head, a cardiac arrest, any neurologic insult increases your risk fivefold for poor outcome. And as I said, that's a important but not novel finding. You might expect it.
Thank you. One of the questions from the audience was, are there any figures on children who were not admitted to the ICU, maybe had lesser form of sepsis in terms of these outcomes?
We have the LAPS investigation only examined septic shock. And so in the United States, at least, those children are typically routinely cared for in the intensive care unit. I appreciate that resource is not available all over the world, unfortunately, but we don't have data for those children.
Okay. Thank you so much for your talk. We really appreciate it. And we'll move on to our next speaker. I'm happy to introduce our next speaker is Dr. Jamie Rylance. He's a reader at the Liverpool School of Tropical Medicine and Wellcome Clinical Research Development Fellow. He's based in Malawi and leads the lung health group at the Malawi Liverpool Wellcome Research Program in Ballantyre. His primary research interest is on the pragmatic clinical management of acute illness in low-income countries and looking at how chronic illness, including HIV and non-communicable diseases, affect clinical management and outcomes. In Malawi, he's examining cardiovascular responses to fluid resuscitation among septic patients, adult patients in Malawi, at the macrovascular and microvascular levels. Dr. Rylance co-directs the NIHR-funded African Research Collaborative on Sepsis. This multinational platform seeks to establish how high-quality care in critically ill patients in low-income countries can be delivered. Dr. Rylance's talk today is titled, "What do long-term sequelae of sepsis look like in low middle-income countries?" And I now welcome Dr. Rylance to the floor.
Thank you very much for the introduction, and many thanks to the organisers for giving me the opportunity to speak. Warm greetings from Malawi, where I work and where I co-direct the ARCS consortium you mentioned. I'm going to present some data from our sub-Saharan African setting, which start to examine the longer-term sepsis outcomes. I have no relevant conflicts. I haven't defined the term long-term here, but to put the outcomes into perspective, I've borrowed from an excellent diagram Prescott mentioned from her JAMA review 3 years ago. Time is represented progressing horizontally from the beginnings of illness on the left, and relative health status is shown on the y-axis. 2 colour lines are depicted here, which trace theoretical clinical pathways through disease. The solid green line indicates a rapid onset of illness, precipitating admission to hospital for sepsis, and the recovery in the aftermath of discharge is good. This may lead to complete recovery, the top branch, some residual improvement, the middle branch, or late decline and death. The dashed dark green line presents an alternative scenario, a more gradual decline and less impressive recovery. 3 longer-term scenarios remain, ranging from full recovery through to death. Apart from the index hospital admission, which I've shown with a green shaded area on the left, I should point out the second green bar, which represents readmission. Coming back to hospital after discharge is relatively frequent in high-income countries, and we've heard that. However, this belies a really complex chain of events, starting with illness recognition and on behalf of the patient, healthcare seeking, re-engagement with health services, and patient transport to definitive care. And all of these may be significantly compromised in low-income settings. Overlaid on this, I've summarised some drivers of outcomes: patient factors in yellow, healthcare factors in green, and pathogen factors in red. I've highlighted 3 boxes which have black borders, which hypothesise are very different in low-income settings in Africa. Firstly, patient status, including age and comorbidities. Secondly, the limitations of existing healthcare interactions and provision. And thirdly, the causative pathogen, pathogen load, and antimicrobial resistance patterns, which were discussed earlier this morning. Lastly, I've highlighted here some of the inherent assumptions that we're trying to unpick with our study, underlying the drivers of poor long-term outcome. Number 1, it matters where you start. So pre-illness functional status is profoundly important. 2, the trajectory of illness, including an indolent infection, which may, in some ways, explain variable outcomes. 3, the quality of hospital care should and does make a positive difference to morbidity and mortality. 4, in the context of immediate sequelae, explanations include misdiagnosis, the direct effects of sepsis on physiology and pathology, and the possibility that hospital admission can be detrimental through a number of mechanisms, including nosocomial infection. And 5, although poor outcomes might sometimes be seen as inevitable based on a pre-existing functional impairment, they more likely result from new or accelerated comorbidities. I'm going to skip this slide and move on to a slide which shows systematic review from high-income countries on the left, showing a patient population with sepsis dominated by older ages. Comorbidities are common, typically high rates of ischemic heart disease, diabetes, malignancy. In this setting and in a healthcare environment set up for intensive care, hospital mortality approximates 17%. Among older individuals, rehospitalization over 3 months occurs in 12%, most frequently a repeat sepsis episode, and slightly less frequency, but most commonly when non-sepsis related, a heart failure exacerbation. Commonly, new function impairments are apparent, as are symptoms of anxiety, inattention, confusion, and physical weakness. On the right-hand side of this, a recent meta-analysis of 15 sepsis studies from sub-Saharan Africa gives no clue as to the outcomes beyond 30 days, but did demonstrate patient populations with high rates of HIV and hospital mortality around the same level as high-income countries. Over the last 2 years, therefore, we've worked in 3 main sites in Malawi, Uganda, and Gabon. We've prospectively recruited adult patients who present to hospitals in these 3 countries. There's therefore a likelihood of pre-selection possible survivor bias, even at the early stage, even at arrival to hospital. Inclusion criteria for this cohort are broad and pragmatic. We've defined sepsis as the need for hospital admission, with the physician suspecting infection. We've excluded surgical, obstetric, trauma patients, which are seen in other cohorts. I'm going to now present some data. This comes with a warning. This is an interim analysis. I'm going to show you the available data from Uganda, 344 patients, and Malawi, 502, approximately 2/3 of the way through our data completion. And these data have therefore not been peer reviewed. But I show you them because I think they are there's very few data anywhere else. Strikingly, there's a young population. The mean age is around 40, frequent HIV infection, and most obvious in Malawi, where inpatient rates are 40 to 50%. Approximately half the patients are unable to walk independently at the time of admission. There are some differences in presenting physiology between the Uganda and Malawi cohorts at present, but the following data, I've combined both sites, and I'll show you these now. Firstly, this graph shows how long patients have been unwell before presentation to hospital. Look at the lines which show the cumulative proportions. The arrow shows that 18% of people have been unwell for more than 30 days and 4% have been immobile for that time. Most people have suffered the presenting illness for more than 1 week, and delays include prior healthcare seeking at health centres in about 64%, private facilities and pharmacy slightly less commonly. In addition, though, delays introduced due to a lack of awareness of disease severity, and in 22% of our participants, insufficient money to get to hospital. I'm now going to show you some outcomes to 90 days from the combined cohort and up to 1 year, which we have available for the Malawi cohort. These are displayed as Kaplan-Meier curves. And firstly, you can see that the Malawi in purple and Uganda cohorts in blue are relatively similar, with approximately a 23% mortality at 90 days. I'm going to show you, take you on a whistle-stop tour of survival stratified by putative factors of poor outcomes. And firstly, HIV status. As expected, those with recently diagnosed HIV who are antiretroviral naive perform the worst, and those with negative or unknown statuses are much better off. These patterns are seen out to 1 year in Malawi, the panel on the right, where ART naive individuals have a survival rate close to 50%. There is a pattern with positive blood cultures. Here I've shown only the Malawi cohort, as this is the only data we have currently. Other research has suggested that better outcomes where the etiology is known, but a positive blood culture infers a poorer prognosis amongst our patients. The blood pressure on admission is unsurprisingly feeds forward into survival. Those with hypotension, in this graph, the purple line, have a worse prognosis. Surprisingly, perhaps, there's no clear divergence in the early days following admission, which might be the expected thing. But the survival deficit does become increasingly apparent and persists at 1 year, as you can see on the right. Also, as expected, hypoxemia is associated with death and early death. Although I should highlight that both the availability and awareness of oxygen supplementation has changed massively in the last year, and that our cohort spans both the pre and peri-COVID eras, which may make some of our analysis more difficult in the future. Lastly, in this format, stratifying the patient population according to their pre-hospital delay suggests very strongly that those with extended illness periods, and here the yellow line is being unwell for more than 1 month, have relatively poor outcomes, and a pattern is unchanged at 1 year. The last slide I'm going to show you is symptoms. We systematically follow up patients at 1, 3, 6, and 12 months. Briefly, the panels here show symptoms left to right of fever, myalgia, confusion, headache, and poor concentration. And the patient is asked at each time point, did you suffer these in the last 2 weeks? Let me just point out the waning rates of fever and myalgia to low levels after presentation, as might be expected. Confusion is not present at 1 year, 1 month, or beyond that. And poor concentration was reported at very low rates throughout. The lack of a control group here does limit some of the interpretation, but we hope to be able to present these data a little later. I hope that gives you an overview of some of the data we've collected to answer the immense knowledge gap surrounding what happens beyond short-term outcomes of sepsis in Africa. Specific questions which arise for our group are shown surrounding the graph here. What's the incidence of sepsis? What drives the different outcomes? And we've spoken about HIV, TB, and non-communicable disease, particularly where there are very high rates of hypertension and diabetes across the continent, at least in pockets. How do we maximize the care quality in hospital? What improvements can we make? And how do we bring patient perspectives to the acute care of policymakers? And lastly, what can we do about post-discharge needs? Do we need to? Is there a role for rehabilitation or surveillance for late effects or missed opportunities? I'd like to thank again the massive number of people that have contributed to these efforts across the ARCS Consortium, to support from the funder NIHR and the Wellcome Trust, and also very many thanks to the participants and guardians involved in the research. Thank you.
Excellent. Thank you so much, Dr. Rylance. Very eye-opening information and sharing. One follow-up question from, because these patients have such a high morbidity and mortality once they arrive with their illness, from a prevention standpoint, how important are strategies for disease awareness prior to these individuals coming in, and even after when they're on their way out of the institution? And how are these addressed locally or on a national level by the healthcare entities there?
Yeah, that's a great question. Thank you. And I think some of the data on the pre-hospital delay speaks to that at least some of our patients tend to stay at home for whatever reason for protracted periods before presenting to hospital. We should be able to show whether this is because they don't have faith in the hospital system, or whether it's that they are unable. And some of these data show that they're unable financially or otherwise to make that trip. There is certainly an educational component which might be able to sensitize people with sepsis or other acute disease to seek healthcare treatment earlier. But we also know that data I didn't show you that approximately 60% of our cohort in Malawi have already been to a health centre. So it's not just the patient recognition, but it's the recognition at the primary care and the first responder type level. And we're working on educational perspectives for that. Of course, in the grand scheme of things, although sepsis is very, very common, it's not that frequent at the village level. And so educational things that focus just on sepsis are unlikely to have a very broad benefit. So we're trying to get the balance right of working out what the emergency signs are, how people can be sensitized to look out for them, and to facilitate that transport to hospital.
Excellent, thank you. One quick follow-up on that. What's the similar response for maybe improving pre-hospital health status? What's being done at the village level so that when they're coming in, they're not already at a disadvantage?
Yes, I think we heard, particularly in the pediatric presentations earlier, nutritional status is important. Certainly for us, HIV status is important. I showed you that antiretroviral naive patients do so much worse. So I think it's a broadly, how do we improve the economic lot at the national level, but then specifically groups at risk, and amongst those in adults, certainly those with HIV, and in pediatric populations with vertically acquired HIV, there's a key opportunity to maximize their immunity and maximize their outcomes if they do develop sepsis.
Absolutely makes great sense. Thank you so much for an amazing talk. And we'll move on to our next speaker. I'm happy to introduce Dr. Timothy Buchman, who has 4 decades of bedside experience caring for septic patients. He's a general surgeon, intensive care doctor, and a virologist. He's currently senior advisor, IPA, to the Division of Research, Innovation, and Ventures, Biomedical Advanced Research and Development Authority, Office of Assistant Secretary for Preparedness and Response at the U.S. Department of Health and Human Services. Dr. Buchman's other current roles, because he has a lot of other time apparently, include Professor of Surgery, Anesthesiology, and Biomedical Informatics at Emory University, where he founded the Emory Critical Care Center. Dr. Buchman is past president of the Shock Society, of the Society for Complex Acute Illness, and of the Society of Critical Care Medicine. He's editor-in-chief of Critical Care Medicine and Critical Care Explorations. Dr. Buchman's current research focuses on the use of artificial intelligence to predict which patients in the ICU will become septic. Dr. Buchman's talk today is titled Societal Costs of Surviving Sepsis, Healthcare System and Out of Pocket. We welcome Dr. Buchman to the floor.
Hello, it's a privilege to be here today. The opinions expressed in this talk are personal and may not reflect the position of the journals or of the Society of Critical Care Medicine. The opinions expressed today are personal and do not reflect the positions of the United States government or agencies thereof. The basis for this talk are 3 manuscripts published in the journal Critical Care Medicine and presented as late-breaker articles at the 2020 Congress of that society. The trilogy is entitled The Burdens of Sepsis, The Trajectories of Sepsis, and the Methods, Models, and Forecasts of Sepsis. By way of background, according to the Centers for Disease Control and Prevention in the United States, there are 1.7 million adult cases and 0.27 million deaths each year. Globally, based on the Rudd paper, the global burden was about 49 million total cases and about 11 million total deaths. These data published in 2020. Who are the at-risk populations, according to the United States Center for Disease Control? In particular, they're adults 65 years of age or older, people with weakened immune systems, those with chronic conditions such as diabetes, lung disease, cancer, and kidney disease, and then, yes, children. Our focus today, though, is going to be on the adult population and those with chronic conditions. Why? Because those are the patients who are covered by the U.S. Center for Medicare and Medicaid Services, that is the United States insurance program for caring for those individuals. And this was a healthcare quality improvement study undertaken by BARDA and CMS. Our focus was to evaluate the burden of sepsis in this population, to estimate contemporary national sepsis costs, and to forecast future Medicare costs for sepsis care. Again, this is a federal health insurance for those greater than 65, some younger people with disabilities, and people with end-stage renal disease. Generally speaking, CMS accounts and the Medicare program accounts for more than 21% of U.S. total healthcare costs, which is 6 times greater than the largest private payer. Our beneficiaries can select either fee-for-service, that is a traditional payment program, or Medicare Advantage, which is an HMO type plan. The Medicare population is increasing. It increased 22% from 2012 to 2018, and the projected growth is from around 60 million in 2018 to more than 80 million by the end of this decade. Now, the data that we're reporting involves just under 9.6 million total sepsis inpatient admissions, including acute, long-term psychiatric and rehabilitation patients. The split on fee-for-service and Medicare Advantage is as shown, and we'll be talking about 6.7 million acute hospital sepsis admissions and about 250,000 other inpatient hospital sepsis admissions. Importantly, we'll be speaking about sepsis present on admission and sepsis that's acquired in the hospital. The data set spanned the United States transition from ICD-9 to ICD-10, and the cases were stratified according to standard ICD coding, as shown on the right. At the left, you can see the significant steady rise in hospital admission rates that were coded for sepsis. You can see that this rose from about 0.2% at any given time of the total number of enrolled beneficiaries to close to 0.3% by the end of the study interval. We noticed that the sepsis claims increased steadily per capita, even as the Medicare beneficiary total population increased, so that in 2012 there were just over 770,000 Medicare sepsis admissions, and by the end of the study period in 2018 it was over 1.1 million. As you can see in the diagram, the non-severe sepsis cases far outpaced those that had septic shock and severe sepsis. There is seasonal variation observed during the winter months. That in the United States is the roughly December through February period. The question always comes up, is this a coding problem or is this an illness problem? On the right, I've reproduced the information showing septic shock in aqua, severe sepsis in purple, and then the various non-sepsis codes in green and red. On the left, I've broken them down into proportions. And the point is that from the beginning to the end of the study, if we look at the most severe forms of sepsis, that is septic shock and severe sepsis, these are unmistakable diagnoses, the proportion of the total remained constant. So if that was a coding problem, we might expect a disproportionate fall in those numbers. We did not see it. We do not think this was a coding problem. We noticed there was a rise seen in admissions exclusively in the present on admission group, the increased fraction from 87% at the beginning of the study to 93% by the end of the study in 2018. And again, there was a reciprocal fall in the hospital-acquired sepsis shown in the diagram in red. The mortality trends were favorable. Sepsis mortality did reflect sepsis severity, and that mortality accumulated over 1 week, 6 months, 1 year, and 3 years. That mortality did decrease in the 7-year period. Non-sepsis mortality at the same interval had no change, suggesting that sepsis diagnosis and treatment is effective. Nevertheless, there is still a very high 3-year mortality, 75% for septic shock, 60% for non-severe sepsis, and 40% for the undiagnosed organisms. Now, what about the economic burdens of sepsis? In 2016, Torrio and Moore reported the 2013 costs reported for the entire United States for the inpatient diagnosis of septicemia as $23.7 billion. That year, it was the most expensive condition treated, and the Medicare population accounted for $14.6 billion, 61.5% of cost. Now, in fact, the cost per case had declined somewhat and then appeared to plateau a bit in the calendar years 16, 17, and 18. The average claim in 2012 was about $21,900. It's a very expensive cost. When we add those costs in to the costs of sepsis for patients transferred to skilled nursing facilities, we begin to get a total picture of the 2018 Medicare sepsis spend. On the left are the inpatient costs in blue, fee-for-service, in green, Medicare Advantage. Those totaled about $33.3 billion. The skilled nursing facility costs required for patients who required ongoing nursing care, unable to go home after their hospitalization. Again, these are just Medicare beneficiaries, more than $8 billion, totaling $41.5 million. If we projected forward into 2019, those costs were up to more than $44 billion. And if we project forward, if we actually look at those costs, the actual costs were higher still, approaching $44.3 billion. Now, again, those are just the Medicare beneficiaries, and we can back calculate from the fraction of Americans who are non-Medicare beneficiaries, but who still became septic. And we estimate that the inpatient costs alone in 2018 and 19 would approach 53 billion US dollars. But that's not the only cost that we should be measuring. We have to ask, where are these patients 6 months after discharge? On the left, the sepsis patients. On right, other hospitalized patients who did not carry a sepsis diagnosis. And you can see by comparing the data that the sepsis patients, fewer of them went home, more went to a nursing home, more went to a skilled nursing facility. Nearly a third died 6 months later. 1.8% were preparing to die in hospice, and 1.2% were back in the hospital. If we ask if the patient had to go from the hospital to a skilled nursing facility first, did they fare better or worse? And unfortunately, they fared worse. On the left, the sepsis cases. On the right, non-sepsis admissions. Fewer patients went home, more went to a nursing home, more went to an inpatient hospital, and an astounding fraction, more than a third, who went to a skilled nursing facility initially ended up dying anyway, with 3% then in hospice getting ready to die. Now, these unfortunately are not the only costs, because this calculation, these data did not consider the initial pre-hospital or outpatient care. They did not consider the professional, the physician fees during the inpatient or skilled nursing facility stays. It didn't consider the care of our nation's military veterans or those who are in active military service through our VA and Defense Health Agency hospitals. It didn't consider the costs of the skilled nursing facility for the non-Medicare patients. And it didn't consider the costs of home care, of medical supplies, or the loss of productivity after the patients had been successfully discharged to home. So we conclude that sepsis inpatient admissions are rising, and they're rising at a rate almost double the Medicare beneficiary population growth as a whole. The inpatient mortality rates are coming down. The patients are doing better. But even so, a sepsis hospital admission is associated with a 60 to 75% mortality rate after 3 years at all severities. The cost per admission appeared to be declining, but may in fact now be leveling off. And the total cost burden to society is unknown. All we can say is it is massively underestimated. Thank you so much for the privilege of speaking today.
Excellent. Thank you so much, Dr. Buchman. Very overwhelming numbers that you've shared here. Just takes you to a point to understand, how severe this is in the high income countries. And it leads to our questions from the audience. Were quite a few about low middle income countries. I know that was not part of your presentation, but the questions were, how are some of these things that are so difficult to address in high income countries to be addressed in low resource countries that don't have all that expertise or the funding and resources that the high-income countries do. What are your thoughts on that?
By far the best strategy to reduce costs is sepsis prevention. The investments that are made in public health, hygiene, vaccination, and so forth, as we have seen in the COVID era, clearly are by far the better strategy, not only to reduce the immediate costs of sepsis, but also those longer term costs, both of aftercare, but most importantly, the loss of economic productivity.
Thank you. Because these costs are so enormous, do you feel that there's an appropriate response from organizations in the US, for instance, like CMS, to try to mitigate this? And what is that response? What's their planning? What's their kind of outlook?
I can't speak for CMS per se and for planning. I'm now speaking as an individual who's been looking at this situation for a very long time. The key to managing and reducing the costs and impact of sepsis when it occurs is early diagnosis and appropriate intervention. I speak now very generally to point out that so much of our sepsis diagnostic prior to COVID depended on technologies that were 2 centuries old. Culture, sensitivity, and treating in the blind, not knowing whether or not the patient is infected, seems to be a poor strategy in the age of molecular diagnostics. My view is that the strategy forward is going to be a different type of partnership among public health agencies, hospital laboratorians, and clinicians, so that we get the right test at the right time, so that we can give the right care right now to every patient, every time.
Wonderful. One last question. Do you know of collaborative work going on looking at these findings of incidence, determinants, and outcomes with sub-Saharan Africa in those areas?
I'm not familiar with that area.
Okay, wonderful. Thank you so much for this wonderful talk. And we'll move on to our next speaker. I'm happy to introduce Dr. Elie Azoulay. He's professor of medicine and head of the critical care department at St. Louis Hospital in Paris. He completed his training in pulmonology and critical care in 1996 and a PhD in respiratory physiology in 2002 on chemotherapy and GCSF-related pulmonary toxicity. He has been part of the editorial board of several international journals and the editor-in-chief of Intensive Care Medicine from 2012 to 2018. His research interests have focused on critical care management of patients with hematologic malignancies and toxicity from chemotherapy and immunotherapy. He launched in 1996 the FAMIREA, multi-center, multidisciplinary study group, aimed at improving the effectiveness of communication with family members of ICU patients. Dr. Azoulay has published more than 400 peer-reviewed articles and is the president-elect of the European Society of Intensive Care Medicine. Dr. Azoulay's talk today is titled Caregivers, Outcomes After Sepsis and COVID-19. I welcome Dr. Azoulay to the floor.
Thank you very much, Dr. Malik. I hope that you can hear me well. It's a big privilege to share this session with you and to speak after Dr. Buchman and before Dr. Herridge, and within this session with plenty of talents of our specialty worldwide. I will have the privilege to present on healthcare providers' outcome during the pandemic. Clearly, we have now many experiences and many feedback from colleagues, nurses, doctors, juniors, more senior people, and other allied healthcare professionals saying that they are exhausted. There are many experiences where people can share their pictures, can share words. Overall, our commitment is to understand what is going there, to make maybe a kind of diagnosis and maybe to be helped by specialists and to try to make everything to reverse what we observe. Clearly, when we give voice to frontline healthcare workers, we can see that there are many words on different things like solidarity and support from from different colleagues. But also, when you look at the small words, you can see that there are tensions, there are conflicts, there is exhaustion, and there are many different symptoms like anxiety, depression, stress, and many conditions that are maybe symptoms, but maybe the start of more structural disease and mental health care issues. Clearly, it's time now to care for the caregivers, not after, but at the same time, we have to care for COVID-19 patients and family members and the society overall. What we can understand, and this is a very nice contribution from Dr. Mehta and Dr. Herridge from Toronto, to which I was privileged to take part, were clearly, because of the surging demand, the fear, and many other symptoms, and facing death, facing very difficult conditions, facing irreversibility, but sometimes facing uncertainty, we are in a situation where we develop many different symptoms. These symptoms can be either insidious or sometimes be voiced by the colleagues, and we only need to listen, but also to look at people to better understand the clinical situation. So I would like to take this framework and to start by reporting on how was the critical care environment before the pandemic. Clearly, sometimes treatments are taking so much space that we don't see the patients behind the machines. And this is a classic criticism that we can get from nurses and sometimes junior doctors. Also, clearly, we know that patients are, the nurses are more into the rooms than the doctors, because we have, as doctors, more patients than nurses. And one of the criticisms that has some strong grounds, but also can be discussed all the time, is that we are leaving the room without addressing all the problems. We have certainly addressed the medical issues, but not the qualitative issues and how people are doing. The patients, of course, the family members, but also the entire interprofessional team. When we looked at the prevalence of conflicts in our ICUs, we were surprised 20 years ago to see that more than 70% of the clinicians were reporting ICU conflicts, and these ICU conflicts were much related to strain, which is a surrogate marker of burnout. This is another study that was performed also on the behalf of the European Society of Intensive Care Medicine, where a number of ICUs, 82 ICUs in 9 countries, reported on the perception of inappropriate care. And COVID-19 is an exacerbation of something that existed already. And this perception is clearly associated with the intention to leave the ICU, but also with many different symptoms. One can be voiced as moral distress, for which a definition is quite difficult to get, but other may describe things like burnout syndrome and symptoms of stress and dissociation that clinicians can present when they are facing this perception of inappropriate care. Of course, it's mostly excessive care, much than not enough care at a patient level. When we are interested by the nurses and when we look at how nurses cope with the stress of managing patients, and this was much before the pandemic, this is a wonderful contribution by the group of Mark Moss, where they reported on post-traumatic stress disorder in nurses. So everyone can understand that the post-ICU syndrome in patients and family members includes PTSD. But this was one of the first descriptions of PTSD in ICU nurses. And clearly you can see that the traumatic events are numerous and not only include patient's care, but also post-mortem care. And I think that this is a very important study that describes how and offers opportunities to improve the way we are doing critical care at a global level and improve the experience of our colleagues when we are providing care for patients in the ICU. Many different situations, exhaustion, depression, general anxiety, PTSD, perception of inappropriate care, and moral distress. So these different symptoms have actually the same determinants. They are about communication gaps, they are about behaviors, they are about decision making, about family grief, about the strain, and about the working hours. Clearly, we are lost into symptoms and syndromes, but overall, when you take one of these different domains, you can see that the determinants are the same. So providing burden might lead to different symptoms, but trying to reverse and offering opportunities for improvement actually might have the same targets. When we look at burnout, you know that no one will come to you to complain for burnout. You, as an ICU leader, need to understand the symptoms of burnout, need to understand the exhaustion, the depersonalization, so you don't recognize your colleague who is different, and the reduced personal accomplishment at work. And we know that we need to understand this feeling of burnout, these different elements, these quotes that might come from colleagues that include, for example, cynicism or sometimes expectations that are not at odds with the situation, and then get to this very high prevalence of burnout that existed before the COVID-19 and of course are increased and exacerbated with the pandemic because of the surge, because of the difficult situation, because of the uncertainty, but also because of the social conditions and the different things. This is one of the last papers that was before the COVID-19 pandemic and clearly provided psychological burden on healthcare providers. And clearly we can see in this paper that before the COVID-19, prevalence of burnout was almost 50% in nurses and doctors. COVID-19 has brought additional strain and additional stress and sources of burden on the healthcare providers. Clearly, we are all living in an area of quarantine, and the lockdown has deprived everyone from any social compensation of what we live. Also, clearly, when we look at the frontline healthcare providers outside the ICU, you can see that the prevalence of anxiety and depression are almost 20%, and insomnia is reaching almost 40% of the cases. So our colleagues, ourselves, are really into a situation where even outside the ICU, things are very, very complex. When we are getting inside the ICUs with the frontline nurses, we see that burnout can reach 50% of prevalence. And we know that there are variations across countries, maybe because of the very heterogeneous effect of the pandemic at a global level, but also maybe because the ethical climate, or maybe sometimes the way the decisions are made and the relationship with patients and family members may be very different. For example, restrictions in visiting hours that have been recommended in the hospitals during the pandemic might have been observed very differently from one country to the other. And we know that clinicians facing the ICU without family members have been very much concerned and affected by this burden. Again, when we are measuring, this is the first paper coming from China showing that symptoms of depression were 50%, anxiety 45%, insomnia 34%, so much more than outside the ICU. And when we looked at this data in France in 21 ICUs, we had exactly the same prevalence of symptoms, 50% anxiety and 30% depression. And as we were in the first wave, we did not measure PTSD or burnout. We did measure peritraumatic dissociation, which is an acute complication of acute stress disorder. Clearly, when we look at these symptoms, we also are able to identify modifiable determinants of these symptoms, like fear. We know that clinicians face the fear of being infected or infected family members, the inability to rest, inability to care for family, the difficult emotions, the restricted visitation policies, and the hasty end-of-life decisions. So perception of suboptimal decision making has been one of the major determinants of this burden, and excessive care, or at least disappropriate care, has also been a major determinant of mental health symptoms in clinicians. So clearly we are at a time for action. We need to target ICU professionals and family and friends, because we know that people we live with need also to understand the situation of healthcare providers, because they are themselves affected. They are one of the major collateral damage. And we know that family members of caregivers, of ICU caregivers, of ICU healthcare providers are themselves affected. We need to have a call for action towards ICU leaders, nurses, medical doctors, and other administrators. And we need to target many different levels to hope for improvements. Clearly, we need to deal with burnout, to recognize it, knowing what are the feelings, to reverse it, and to build resilience with our teams. What we can do is, one of the very simple things we can do is to report about it, to speak about it, to listen to colleagues, and to have support groups. There are some cognitive management, CBT management, that has provided some information. But at this time, these are only hypotheses. We can try mindfulness, and we are convinced based on preliminary results that it is effective, but we need more evidence. We can also improve communication within the teams, because we know it is a very good way to decrease burnout symptoms in healthcare providers. We need to improve communication, cohesion, to promote well-being within the team as much as possible, to offer maybe naps in the ICU. We know that we also have preventive measures and kind of isolation within clinicians, but we need to do things and to have psychological support from specialists and also from colleagues. In the same way, we need to provide clinicians with things that are ready for them to use, like, for example, to make recommendations about end-of-life care, to make recommendations about how we are going to lead a discussion with a remote family, how we can speak with them, and how we can improve the way we provide information to people who are not in the ICU because they are far, because they are themselves sick, or because they are imposed restricted visiting policies. And we also need to have guides to talk to relatives when we are facing the very difficult situation of end of life. At this stage, I would like to finish my presentation by saying that I was very happy to share this session with you. But the strategy and the way we are going to get out of this is the same for all of us. And I also think that we, as the critical care global community, we need to communicate more between us and maybe to help each other to cope with this situation and to pass the situation of distress. Maybe if you have a good idea, we would be very happy to share it, and any good idea from our side would be also for you. Thank you very much.
Excellent. Thank you so much. That certainly gives everyone more food for thought. It's being echoed in the chat. People are certainly responding to what you're sharing, saying that it's a very important subject. It's a huge problem for our healthcare system. And people are sharing that up to 50% of their colleagues are suffering from this. It's very clear and obvious, even more so than it was before COVID. And that nurses and other professionals on general wards are affected by this as well. I mean, it trickles down very clearly. one question that came up was, in addition to the awareness, cohesion, communication, everything that those methods that are helpful, is there anything in particular about our experience with COVID-19 that's helping us highlight new methods of how we should be trying to address or manage some of the stress or the PTSD the healthcare workers are dealing with?
That's a very good question, because many things have been attempted during this pandemic, but I would say that it's still early to provide any concrete recommendations. One of the things that is obvious is that there is a lot of frustration, as we cannot be a real group with this cohesion is also limited by the need we have to stay apart from each other because of the new variants. And even if we are all vaccinated, we may be, susceptible to new variants, and we need to be able to avoid circulation of the virus inside the ICU. Still, there are a lot of things that have been done. Just for example, those clinicians who have had, their pictures among the PPE or their name, and they have made some videos, and just the way that the feeling that they were really able to help family members and to help the patients pass this very difficult tunnel and this very difficult moment was very good at the clinician level. So one of the frustration was also that they were not really able to provide the best care for patients and for family members. So anything they can do to welcome family members or to do something to bypass the frustration of the PPEs and the fact that you cannot recognize any clinician in the ICU is a good thing. The other thing is that all the things that we do to pass the burden is on Zoom. So we are not together, we see each other, so it mimics the real life. But by providing a solution that is Zoom-based is also a frustration, because you cannot touch, you cannot share, you cannot really see others. So we need to work on this. My recommendation is to take the entire team on projects that will be for after COVID. So it's taking everyone to a hope that makes that in a few months, we are going to go back to our normal life with the problem of the normal life, but with its strength. And we know that we together, we want to share, we want to discuss, we want to see each other, to smell each other, something we don't do anymore, and to be able really to maybe debrief, taking people in the future and giving them the light of a close future where we will be again in a capacity of being together and maybe fighting again, but we will be again together, is maybe a good thing to think on.
Absolutely. I think having a light at the end of the tunnel always helps keep us going forward. Thank you so much for this wonderful
talk.
Very much. I'm happy to now introduce our final speaker. Dr. Margaret Herridge is a professor of medicine, critical care, and pulmonary medicine at the University Health Network, senior scientist in the Toronto General Research Institute, and director of research for the Interdepartmental Division of Critical Care Medicine at University of Toronto. She completed her research training at the Channing Laboratory, Harvard School of Medicine, Public Health. Harvard School of Public Health. Since 1997, her group has completed 3 cohort studies, one in survivors of ARDS, one in survivors of SARS, one in patients with post-mechanical ventilation and their family caregivers. Currently, Dr. Herridge is co-leading the Canadian Prospective Multi-Center 1-year cohort study of COVID-19 patients and caregivers. She is director of the Recover Clinical and Research Program for patient and family-centered follow-up care after critical illness, and clinical director of the long-term ventilation program, GRACE Recover Program for chronic critical illness. Dr. Herridge has led editorials and manuscripts in the New England Journal of Medicine and is a frequent international speaker on outcomes after critical illness. Her talk today is titled Long-Term Outcome of COVID-19, and I welcome Dr. Herridge to the floor.
Thank you very much, Dr. Malik, and thanks so much for the opportunity to speak to you today about long-term outcome of COVID-19. It's always a pleasure to follow Elie, and thanks to all the speakers for wonderful talks this morning. I wanted to briefly say I have no conflicts of interest to declare, and I have no relationship with industry. I think when we think about the outcomes after COVID-19, it's very important to address this in the construct of multi-organ dysfunction. This is something we're very familiar with in critical illness in general, but the emerging COVID-19 literature helps to teach us about certain end organs that are targeted, that are particularly relevant because they have a lot to do with functional outcome and our day-to-day life, including injury to the brain, injury to our heart, injury to our lungs, and the severe lung injury and ARDS that these patients sustain, renal injury, and the complications of this. Furthermore, I think it's very helpful to think about these constellation of challenges, these end organ challenges, using the post-intensive care syndrome construct. And this was led by Dale Needham, and really helping to bring together the ICU outcomes literature for both patients and families, focused on mental health, cognitive, and physical impairments. Recently, there's been sort of an augment to this original construct, the concept of an extended PICS. This was recently published in Critical Care, led by Russo and other colleagues, to extend the PICS to include more multi-dimensions in terms of patient outcome, and also to endorse the continuum of care. Who you are before you become critically ill has a lot to do with your long-term outcome, as well as the importance of the long-term outcome sequelae as determinants of long-term healthcare utilization, cost, and these other challenges that many of which Dr. Buchman outlined in his talk. One additional construct that's important that was not included in the original PICS definition is frailty. This is very, very nicely outlined in a recent paper in Critical Care Medicine by Nathan Brummel, pardon me. Our own Recover program has attempted to highlight the multimorbidities here, pressure injuries, intra-abdominal sepsis that can also influence outcomes. So multimodality outcomes, when we're thinking about the brain, I think it's important to look at prior literature. And here's the landmark paper published by Mona Hopkins, showing that patients after ARDS, and most of these patients were survivors of sepsis, they had decrements in processing speed, memory, executive function, attention, and concentration. So to learn from the prior literature, including the prior sepsis literature, and one of the outcomes leaders in the sepsis literature, Jack Awashina, more recently Hallie Prescott, and showing that after sepsis, there are important decrements in cognition, also shown in the important New England Journal paper led here by Pradip Pandarapandi with Wes Elie, showing again important decrements in survivors of critical illness in cognition, measured by the Arban's cognitive scale on the order of mild Alzheimer type dementia and a moderate traumatic brain injury, and across age tertiles. So we're seeing robust literature already showing cognition, but also in these data published by Jim Jackson, mood disorders, prevalent mood disorders across age tertiles, here showing depressive symptoms and also symptoms of post-traumatic distress disorder. I show you this background, this historical background in the outcomes literature, because I think looking at that really helps to inform what we might anticipate in COVID-19, those similarities, and exploring those differences that may be unique to this viral infection. Here's here's a seminal paper led by Brenda Poon, and showing how prevalent delirium is in patients with COVID-19 and the important risks of, continuous sedation, continuous exposure to narcotics, the use of physical restraints, and also important mitigating factors, things that we know historically helped our patients, having a loved one, excuse me, a loved one, family member at the bedside, and how now we've completely disrupted this opportunity to attenuate delirium through the isolation that our patients are currently experiencing. Our group and other groups around the world have looked a lot at outcomes after ARDS. There's an outcomes literature in SARS as well. And the outcomes literature is important because, again, it can inform what we might expect to see in COVID-19 patients. In our Toronto ARDS cohort, we saw that patients had important functional disability captured as distance walked in 6 minutes. In the SARS data as well, there was important functional disability. And interestingly, in survivors of severe ARDS and survivors of SARS, there was normal to near normal pulmonary function. And pulmonary function gradually improved over time. And the observation that in severe ARDS patients, thinking now about pulmonary outcomes that may be relevant to COVID-19, those pulmonary outcomes and disability outcomes may not reach premorbid functional levels. And in the ICAP cohort and other international cohorts, this cohort led by Elizabeth Foe and published in ICM shows not only decrements, but also declines across different functional domains over time. Well, as the outcomes literature begins to emerge internationally, we look first to China and their experience, and we will begin to publish outcomes literature moving east to west. And this is an important cohort study led by Bin Cao from the Wuhan group, showing 6-month data now, and reinforcing some of the outcomes that we've seen previously published in the sepsis literature, in the ARDS literature. High prevalence of symptoms, and you can see here fatigue and muscle weakness, sleep difficulties, alopecia, very important symptoms that are being reported. I would say also 60-day outcomes published recently in the Annals of Internal Medicine by Hallie Prescott's group endorsed very similar outcomes. So we're seeing these robust themes emerging. In Bin Cao's cohort, you can see that at 6 months, there is still some degree of pulmonary dysfunction with a reduction in lung volumes. One might expect, if this is similar to the ARDS literature, that these will continue to improve over time. It's important to note as well that the CT findings of ground glass opacifications that are virtually ubiquitous are still quite prevalent at 6 months. And again, based in the SARS literature and the historic ARDS literature, we might expect that these would resolve over time, and we will follow these results carefully. In another important cohort group from the comeback study showing their 4-month clinical status outcomes, I think it's important here to reinforce as well that as shown in the previous sepsis and ARDS literature, there's an important signal in psychiatric symptoms and cognitive impairment, and similarly with dysfunctional breathing. As we move forward, there are many groups. Dr. Tong has led one of these groups, and this is a very nice publication in Critical Care Medicine recently, bringing together experts to determine core outcome sets so that we can really capture the complexity, the multidimensionality of outcomes after COVID-19 for patients, for caregivers, as Elie alluded to, both professional and family caregivers. So I'm just going to close by saying that COVID the early emerging literature definitely seems to share many of the similar robust themes that we've already seen emerging over 20 years or so in the outcomes literature, in sepsis, in ARDS, that there is newly acquired disability or exacerbation of pre-existing disability or comorbidities or vulnerabilities. And this may lead to an important public health really tsunami of age-inappropriate healthcare resource use, and the importance of really evaluating the health policy implications of these long-term healthcare needs to really address the sequelae of multi-system injury, the sequelae of prolonged critical illness for these patients, the sequelae of specific elements of COVID-19 that we may still need to understand, traumatized family caregivers, and really understanding how to modify our systems around the world, which currently are really not prepared to meet these longitudinal healthcare needs. I thank you very much again for the opportunity to speak today, and look forward to chatting further. Thank you.
Thank you so much, Dr. Herridge. Wonderful talk, and so much to consider, given that we're just seeing the beginnings of this data. We're getting just the tip of the iceberg of what's kind of coming ahead. Knowing that we are perhaps very inadequately prepared, what are some of the strategies that different organizations are planning or thinking about to try to be prepared for this, or at least have a chance at it?
Well, thanks for that wonderful question. I think we really need to make sure that we don't try to reinvent the wheel. I think I tried to show a lot of the prior outcomes data from many international groups to emphasize that we already know a lot about the sequelae of, at least speaking in the context of critical illness, about the long-term disability. I think as a community, as an outcomes community, we're still struggling a little bit to know precisely what to do about that. But definitely understanding potential mitigating factors, and Brenda Poon's paper is very instructive in that way. In real time, understanding how we've really largely departed from a lot of the tenets of critical care that we know helped outcome, like having patients awake in the ICU, not in deep coma, physical contact with patients from caregivers, from family members, and truly trying to implement early mobility. Many groups have published extensively on this, and really creating a continuum of care for rehab to address not only the ICU-acquired weakness sequelae, but also, importantly, the mental health and cognitive issues. Many of the leaders whose work I've briefly cited today are actively engaged in that, but really to understand what we already know are robust challenges after critical illness, and then adding to that what might be more specifically related to COVID-19. Is there more cognitive overlay in these folks because of the ACE2 receptor expression in the brain in particular, just as one example. So I think my message would be important to learn from the past, modify what we already know, and extend that knowledge into what might be more specifically related to COVID-19.
Thank you. Do you feel that because this pandemic has really grabbed everybody's attention, and there has been a lot more efforts to putting resources behind the various treatment methods, prevention, and now what we're talking about in terms of sequelae, do you feel that hopeful that there will be a lot more resources put towards this as well as we go forward?
Yeah, I mean, I really think so. I feel optimistic about that. I feel and I'm sure many people who study outcomes. One silver lining to what's been an extraordinarily difficult time in so many ways is that never in the history of the world have there been so many survivors of critical illness or sepsis. And in such a public way, that everyone understands now what ventilators are and what proning is. And I mean, it's rather extraordinary. But I think it allows us an opportunity, a window in time to advocate for patients, for families, to advocate for system change, to advocate for health policy change, that we can really address a lot of needs that have largely gone unmet across our different healthcare systems, to really openly talk about how healthcare systems are different, how access is different for people of different economic advantage, how it's different for racialized groups, regardless of the country you live in, and even in a country like Canada, where we have universal access, there is still differential access for many, many people. And this is a great opportunity to have a very hard look, a very sobering look at what we're doing and how we're really meeting needs, because it is so public what we're having to deal with. I think it's a great opportunity for change. These things are being really laid bare, made transparent to the larger public because of the media attention and the disruption.
Absolutely, and I really hope that we can capitalize on that attention from media, from the public, and all the resources that are being put towards it, to make sure that we're addressing the whole spectrum of this disease, from the beginning to what we're doing in the hospitalization to what's happening to them at home. So thank you so very much for this wonderful talk. And now, as we conclude this session, I would like to thank our wonderful speakers for helping us better understand these various important aspects of the long-term sequelae for our patients, as well as healthcare workers from sepsis and COVID-19. I want to thank our audience members and encourage them to visit the Global Sepsis Alliance website, sign the World Sepsis Declaration, and follow GSA on Facebook, Twitter, and Instagram for details regarding the availability of the talks from this session on YouTube coming out soon, and also looking for our future Congress dates in 2022. I want to thank you very much for sharing this time with us, and encourage everyone to continue the conversation about long-term sequelae, and everyone be safe. Thank you.